So, what is narcolepsy? Popular media depicts it in a way where you're suddenly collapsing or suddenly falling asleep mid-conversation. But majority of narcolepsy patients are not like that. Let me name a few other symptoms that we commonly see in this group. One of them is sleep paralysis. They end up having the sleep paralysis episodes way more frequently. The other one are hallucinations, but only when I'm about to fall asleep or when I'm about to wake up. It takes them multiple alarms to wake up in the morning. The biggest misconception here is that somehow it has to be very, very dramatic, which is in 95% of the patients, that's not the case at all. If you're not an observant, you could easily think, oh, this person's dealing with insomnia, and you keep trying sleeping pills or whatever, but it's not really helping them because they're super tired. You really miss the diagnosis of narcolepsy.
Welcome back to the Hidden Sleep Disorder Show, where we uncover the science, diagnosis, and treatment of sleep disorders that often hide behind chronic fatigue, poor sleep, and unexplained exhaustion. Today, we're going to take a closer look at one of the most misunderstood sleep disorders, narcolepsy. Many people have heard the word narcolepsy, but what they think it means is often very different from the medical reality. Some imagine people suddenly collapsing or falling asleep without warning, but narcolepsy is much more complex than that. And for many patients, the journey to diagnosis can take years. So, this is an exciting episode. I know I'm excited because I definitely think of narcolepsy. And so, I'm happy to dive into this episode with you, Dr. Saini. How are you doing today?
I'm doing great, Leila. Let's start this off. Let's dedicate this episode to all our nighttime sleep techs who work really hard and serving our patients for working nights and making a huge impact. So I would like to dedicate this episode to all our sleep techs.
Absolutely, for sure. Yeah, that's definitely not an easy job to have at all. So let's hop into talking about narcolepsy. I think everyone has heard the word narcolepsy, but I think that most people don't really understand it. So can you tell us what exactly narcolepsy is and how would you explain it to someone hearing about it for the very first time?
When you were introducing, you hit it precisely that most of us believe popular media predicts it or depicts it in a way where you're suddenly collapsing or suddenly falling asleep mid conversations, which can happen and does happen in severe cases. But majority of narcolepsy patients are not like that. So there is a huge misconception. So what is narcolepsy? And we'll dive down into the mechanism. What exactly is happening in our brain is we need neurochemicals that are playing a symphony in our brain. If the sleep ones are higher, then we tend to be sleepy. If the wake promoting ones are higher in our brain, then we tend to be awake. And to manage this whole symphony, there is a chemical called orexin that is generated by our neurons in the brain. So those neurons get somehow malfunction. They get destroyed or they're just not working to the extent we need them to. So because of that, there is lack of orexin happening. And that's what narcolepsy really is. Lack of that orexin chemical, and that is the mechanism behind it. Now, there are multiple pathways how those neurons can get destroyed. Sometimes it's post-infection. Sometimes it's autoimmune. Sometimes it's just a random act of nature, and we don't really know why it triggered for that particular person. Sometimes there is familial predisposition. It could run in multiple members in the same family. So there is some genetic component to it as well. In nutshell, that's how I would describe it to someone who's never heard of narcolepsy in the past is that, hey, this is a condition that can make you extremely sleepy. Your burden of sleepiness is pretty high. So no matter how much I sleep, I'm always still having that need to sleep more.
It is interesting. And I think also we touched on this in the intro that there's a lot of misconceptions about narcolepsy, and people have this preconceived idea of what it is. And I think it's often portrayed in movies or television in such exaggerated ways, which is probably why a lot of people have that thought process around it. But what are some of the biggest misconceptions that people actually have about narcolepsy?
Good question. I actually just saw a narcolepsy patient yesterday, and this is an 18-year-old kid, so the conversation is still pretty fresh in my mind. And he accompanied to my office with his mother, and they're like, I cannot believe this, that my son has narcolepsy. I was thinking, hey, I would be collapsing, but this young man or boy had such hard time waking up in the morning and then trying to stay alert and awake during his school. He's been missing out on school a lot. So the biggest misconception here is that somehow it has to be very dramatic, which is in 95% of the patients, that's not the case at all. And a lot of these patients then end up getting in the pathways where they get moved to, oh, maybe you have depression, maybe you have some other psych disorder. Maybe you have some other neurological condition. Maybe you have some sort of infection. There's all kinds of things that get blamed even before someone gets referred for narcolepsy testing. The one hallmark is there are two kinds of narcolepsy. One that comes with cataplexy, and cataplexy is a fancy word for saying that, hey, I have muscle weakness in response to certain emotions. For example, if I'm laughing out loud watching a TikTok video and suddenly I feel I can't hold my stance, or my knees start to buckle, or my eyes get a little droopy. And sometimes it's so subtle that unless I ask very specific questions and make the patient think really hard, for example, that's the question I asked this young boy yesterday. And guess what he says? I don't think I have it. But then I said, okay, what if you were to laugh out loud? And then he started to think harder and he's, wait a minute, I have hard time holding on to a pillow when I laugh. And I'm like, dude, you don't laugh any other times? How come you're only laughing in bed? And he said, when I'm having conversation with my sister or we're watching something funny, I just noticed that, and I've mentioned it to her several times that for some reason the pillow seems to be heavy all of a sudden because my arm muscles are starting to feel weak. And it's so subtle because he's like, hey, that's how I have been all my life. So he didn't know anything better. So then that's a cataplexy episodes, which is one of the hallmarks of narcolepsy clinically. So that raises my suspicion for narcolepsy even higher, especially when that is present. Now, just to make my life interesting, not every narcolepsy patient is going to have cataplexy. So there is a whole another group of patients who do not have cataplexy. They're just sleepy people walking around between us, but they don't have those cataplexy or muscle weakness. And that's what the popular media is trying to depict, those dramatic falls or dramatic shutdowns. That's what they're trying to depict is the cataplexy part of the narcolepsy.
Okay, that's interesting with this 18-year-old with the cataplexy because, like you said, he's noticed he's been doing it, but no one would ever think that's narcolepsy.
Exactly.
I think with media and going back to that, I think what comes to my mind, and I feel like we may have mentioned this in the last episode, was the falling asleep at the wheel. Just like falling asleep driving or just sitting and just completely falling over and falling asleep. I feel like those are the extreme cases that people
They
associate
are.
with.
I did ask this patient yesterday that, hey, how do you manage driving then? And I can tell when I'm feeling very sleepy, then I don't drive. I either pull over and take a nap. And generally, luckily for the narcolepsy patients, naps are quite refreshing. In fact, that's one of the strategies that we use in our treatments to have this strategic nap to help their brain recover and so that they can go about their business. But majority of the patients, they've already figured this out. So they already take these strategic naps, I call them, to maneuver their day and go about their business.
Interesting. And speaking about that, I know a lot of people, like we said, associate narcolepsy with these sudden sleep attacks. But based on what you're saying and what I'm hearing, it sounds like the symptoms can be a lot broader.
Yeah, let me name a few other
Yeah.
symptoms that we commonly see. in
Mhm.
this group. One of them is sleep paralysis, where, hey, I wake up or I at least feel like I'm awake, but I can't move my body. And it almost feels like I'm locked in my body. And it's a scary thing to experience. And to make things tricky, it can happen in normal population too. And it does happen. So a lot of us may have experienced it once or twice in our lifespan. But these folks, they end up having the sleep paralysis episodes way more frequently than most of us. And it's a very scary feeling because you're like, what is going on? I can't talk, I can't scream. And it lasts for sometimes more than a minute or even longer. And it's terrifying. The other one is that doesn't get commonly talked about are hallucinations, where I'm seeing things or hearing things that are not there, but only when I'm about to fall asleep or when I'm about to wake up. It's not that, oh, I'm sitting here talking to Layla and hallucinating. It's not that. It's only in those particular settings when my sleep onset is about to happen or when I'm about to wake up from my sleep period. Then they'll start having these hallucinations. And that's another terrifying thing. What else do these guys suffer? Big one that I hear complained in clinic is the brain fog, where, hey, I just never feel like I'm fully awake. And brain fog is actually the word that's most commonly used to describe that feeling. It take them multiple alarms to wake up in the morning. They would be setting 5, 7 alarms, or using, now there are some extreme alarms on the market. They'll shock you, do crazy things to you. And sometimes patients go to such extremes just to be able to wake up on time. I had a patient the other day, and she's so distressed. Is, hey, I'm a teacher, I'm 40 plus years old, and I still have to depend on my mom to call me and wake me up. That is so embarrassing that she still has to do that for me. It's like I never really grew up from that or grew out of that. So those are really very common symptoms. The other symptom that's hidden, which I would like to point out, is that even though these patients are extremely sleepy, so you would think, oh my gosh, they must be sleeping really good at night. But the reality can't be farther. These poor folks have double whammy because they are sleepy during the daytime and they're extremely poor sleepers at nighttime. So they can't really maintain consistent deep sleep. And that really is taking a toll on all these patients because I'm sleeping poorly. And that's why a lot of times it's so hard, because if you're not an observant clinician, you could easily think, oh, this person's dealing with insomnia, and you keep trying sleeping pills or whatever, but it's not really helping them because they're super tired, and you really miss the diagnosis of narcolepsy for these patients. So generally, it's a good idea to have a more holistic view and do a thorough testing.
Yeah, and going back to what you said too, especially with brain fog, because I feel like brain fog is something that's so common in so many other diagnoses that it likely goes super undiagnosed or hidden rather when it comes to sleep disorders.
You're right, and that's one of the things with these disorders. Because they're rare, you still have to rule out other common sleep disorders, right? Or even other common medical conditions, lack of thyroid, vitamin D deficiency, depression. All of those still have to be ruled out or managed. And that's why sometimes we see so much delay. But what we're also saying is that, hey, don't just keep revolving or recreating the wheel. If you're not really seeing better outcomes by treating those conditions, then there's probably something more to it, and then it needs to be uncovered.
Absolutely. And now it makes a lot of sense of why narcolepsy can go on for so many years and not be diagnosed. Because even that the patient you mentioned that's in her 40s that got the call from her mom, I can relate to that personally because that was me through my 20s. I had to have my grandpa call and wake me up because I was such a heavy sleeper. And now I'm curious. I'm sure so many people listening are wondering if they have any sleep disorders because I have slept through fire alarms in college campuses before. So I just thought I was a heavy sleeper, but now I'm questioning myself. So this is so good. I'm sure a lot of people listening have some kind of story or thought that they could relate to too. So it's so interesting to think about. And speaking about that, so many patients do have narcolepsy for years without a diagnosis. So beyond what we discussed, but are there any other reasons that you think or come to mind that are reasons for it going undiagnosed or misdiagnosed for so long?
So I think clinician education is a big one. If you've never really seen a case of narcolepsy, then it's going to be extremely tough to even consider that as a diagnosis, right? Educational platforms like our conversation right now is to shed that light and make sure people are more aware of these conditions. So I think that's big part of the delay happening. So as more people realize that, okay, there are testing available, there are people who just focus on these disorders and experts out there. So I think that's really what needs to happen as far as delay is concerned. As far as resources are concerned, another reason for delay that I see commonly is a lot of these patients will have other comorbid psychiatric conditions. And what will happen is a lot of those psych medications impact some of the testing that we do for narcolepsy, meaning they impact or change the brain waves that we're trying to find. So then we have to somehow try to get them off their medications to actually get the real data that might be hiding that diagnosis. And sometimes it's very challenging because if your depression gets out of whack, you don't want to put patients in the harm's way either. There are all kinds of complications that happen around that. So that's another big factor that I see for delay. Third, obviously, this testing takes specialized labs. Testing takes specialized skills from the sleep techs. So not all the sleep labs may be equipped with that. A lot of them are. It's still worthwhile pursuing or asking or then going to a lab that actually does it like ours. There are ways to navigate that, but if I'm not even aware of all this, then how am I even going to navigate this, right? So that's why we're trying to bring it out of the shadows from our platform.
Absolutely. And your first part about it being education too, because there's so many people that have all these issues and it's not common knowledge to go to a sleep disorder specialist. It's usually my primary care doctor and they won't think into it the way someone with, for example, your background would really dive into it and go through, okay, process of elimination sort of thing and really think through it. So it's so good that we're getting this information out. I was actually just talking to a friend of mine earlier today who's having a lot of sleep issues and she's saying it's her anxiety. So now I'm wondering what deeper, I'm sure anxiety plays a role, but narcolepsy overlaps with so many other health issues. But what conditions is narcolepsy most commonly mistaken or confused for?
Most common one that I've seen are psychiatric conditions that get really the blame for, and patients, especially if they have major depression, a lot of times major depression just keeps on getting blamed, and especially because there are so many medications these days available for depression. So by the time psychiatrists run out of the 20, 30 medications that they have at their disposal, it's already been 15 years or 20 years of the time that's already been spent in trying to manage that. And the other trouble is that, hey, because I'm extremely sleepy, it's hard for me to manage. The risk for depression in this cohort is pretty high already. So, yes, we already know they have more depression compared to general population, and that makes it super tricky. So that's one big one. And the other one that we commonly see in the clinic is ADHD. And a lot of times, because I'm sleepy, because I'm tired, I can't focus. And then the focus becomes the main focus, not the sleepiness. And so then when that happens, ADHD is easy to label. And I can't tell you how many patients I see, and they all say yes to ADD, ADHD, but it's really the sleepiness that they're treating with all the stimulants that they use for their ADD, ADHD medications, which, by the way, we also use them or have to use them sometimes, stimulant medications to keep people alert and awake because we know that's what they also help with. But those two are the big ones. Now, obviously, I have to rule out sleep apnea as a cause of excessive daytime sleepiness, which generally most sleep labs and home sleep testing programs are extremely good at doing that. It's readily available, has gotten way cheaper to diagnose or find out sleep apnea. So that's an easy sort of low hanging fruit to get them out of the way. Sometimes we see patients who are taking multiple medications, and then a lot of those medications can make you sleepy too. And a lot of our listeners probably won't realize or won't know that a lot of heart medications, especially beta blockers, and even some cholesterol medications, can also make you very sleepy and tired during the daytime. So all those things have to be looked at and see, okay, what could be triggering this.
And this may be completely inaccurate. What you said made me think about this because with medication and with ADHD, and I even know this from personal experience and just from learning and talking to a lot of doctors and clients and things like that. Sometimes people with ADHD will take a medication to help them focus and it will relax their brain in a way that they finally feel peace versus focus and they'll fall asleep.
You're absolutely right. And that does happen quite a bit. In fact, that's one way I find out that, okay, these stimulants are not going to be adequate in managing this person. And then I have to dig deeper and find out better solutions for them because, hey, they're already feeling pretty strong stimulant medications.
Yeah.
And that's where the science will come to rescue. And we are doing a lot of clinical trials on orexin based medications, and I'm happy to report to all our listeners that we do have now replacement orexins that are being studied as we speak, and we expect them to be commercially available on the market as soon as by the end of this year, and multiple more in the pipeline that will be ready by next year or so. And so we're actively looking at those medications to help replace the orexin molecule or orexin chemical that we were talking about at the start of the show.
That's such like aligned timing. So that's really interesting too. And so speaking about that as well, when someone is evaluated for narcolepsy, what does the diagnostic process usually or typically involve? And beyond that, how does sleep specialists confirm that diagnosis? I know we've talked a little bit about kind of process of elimination, might not be the right term for it, but something similar. But beyond that, are there any other ways that the diagnosis is confirmed?
Yes. So what I'll do is I'll walk through typical sort of patient pathway for narcolepsy where we're suspecting narcolepsy or hypersomnia in a patient. So generally we'll do initial clinical evaluation, do a thorough history and make sure they're presenting with some of the symptoms we covered earlier, right? So once I have a clinical suspicion, so generally they'll undergo two studies. One is the nighttime portion, and that is to ensure that there was enough sleep time before going into the daytime study. So we do a nighttime study followed by a daytime study, and I'll explain both of those and what they're for and what they do. So the in-lab sleep study is one, like I said, to confirm that their total sleep time is at least 6+ hours, so we know they're not sleep deprived, because that's another big factor. If you go into the study being sleep deprived, you can easily fool the test. So we make sure in whatever ways we can that when you go into the test that you've had plenty of sleep several days prior going into the sleep study, because otherwise we may end up mislabeling somebody with narcolepsy. So that's number one. Number two, that in overnight study is also to help rule out conditions like sleep apnea and other sleep disorders that may show up during the nighttime. So once we finish the nighttime portion, instead of sending the patient home, they stay in the sleep lab and we start, after they've been awake for 1.5 to 2 hours, we start what we call a nap study. And nap study is really what we're asking a person to do is we give them a 20-minute interval to take a nap and see what is the propensity of their brain, what is the chance that their brain is going to fall asleep during that time frame. And we're measuring how quickly that patient is going to fall asleep during that nap. Because obviously, we're still recording the brain waves to see, because what is typical for narcolepsy patients for their brains is to go right into REM sleep. And instead of taking close to 90 minutes, which is what normally brain does. For adults, it takes about 60 to 90 minutes minimum to get to REM sleep when you first start your sleep. But with narcolepsy patients, they go into REM sleep right away, within 2-3 minutes, and they're right in REM sleep. So those are some of the features that we're trying to find, trying to look for to see, okay, if that's what would lead us to narcolepsy. Now, does this test work every time? No, it doesn't. A lot of times we run into challenges where we have, especially younger patients, they get super anxious or even older, and sleep lab environment isn't your home environment. So you may have hard time falling asleep, and sometimes that complicates. So sometimes you have to go back and repeat the test. But typically the test is If you follow all the guidelines, then it's generally pretty good when it is able to capture those. That reminds me, one of the things that we ask patients in the clinic itself is that, hey, do you start dreaming right away when you take those naps? And a lot of these patients will tell us that, yes, I start dreaming, my dreams are super vivid. And that tells me that their brain is most likely going into REM sleep as soon as they take a nap. So that's another clue for me to pursue that nap study. So that's one of the main testing procedure that we do for this group. There are, in rare cases, we sometimes, no matter how much testing you do and it's not really showing you the results, or even in some medical legal cases where you have to prove 100% that's what we're dealing with and is someone is not faking all this. So then sometimes there is a test where we check orexin levels in your cerebrospinal fluid or CSF fluid, where we do a spinal tap, draw some CSF fluid, and send it to specialized labs to test for the levels of orexin. And generally, with narcolepsy, which is type 1, they will have very low levels of orexin show up on that lab study. But because it's a painful, very labor intensive test, most people don't really agree to go through that. And obviously, we have less painful, easier tests to do to tackle it. So, generally, clinical suspicion, clinical symptoms, clinical evaluation, followed by the in lab sleep study and nap study. And generally, when you look at all the data from there, you get a much better picture, much more wholesome picture for the patients to really confidently say if we're dealing with this narcolepsy condition or not.
Yeah, there's so many ways it sounds like to really diagnose. But beyond that, for people who are diagnosed with narcolepsy, then what happens? So, what kind of treatments or management strategies are available for people that are diagnosed with narcolepsy today?
So that's obviously dependent on what is most bothersome to that individual person. And I'll give you an example. So let's say my major issue is daytime sleepiness, because some of these patients will sleep just fine at night and others will have very poor sleep at nighttime. So in our conversations with our patients, that's what we're focusing on. That, okay, what's the most burdensome symptom that they're dealing with? And then we start to tailor medications around that. So in narcolepsy, luckily we have more than one option out there now. In fact, we have at least 4 or 5 options that are easily available as we speak. And then, of course, I mentioned to you that there are some new orexin ones coming out fairly soon. So I'm really excited about those as well. So then when we start them generally with daytime medications to see, okay, how impactful they are, and are they able to keep my patient alert and awake and be able to sustain them through their working hours? Or sometimes we employ strategic naps along with the medication. Sometimes the medication has to be timed so that, hey, it may not last for the whole day. Then you have to take it in the morning and sometimes take it during the noon hours so that you stretch it out enough to help them throughout the whole working hours. The ones who have nighttime issues a lot more and they're distressed about their nighttime sleep, so you have to obviously manage that. And luckily, there are medications. There's one liquid medication called Xywav that is approved for narcolepsy that helps patients sleep harder, sleep deeper, and get more deep quality sleep. And in return, helps them stay more alert and awake during the daytime. And it also impacts their brain fog, their sleep inertia that we talked about early on. So there are a lot of tools in a sleep specialist toolkit to manage depending on who is in front of us and what is burdening them or bothering them the most. And then it's always nice to have that conversation to come up with a very customized, personalized treatment plan to help them achieve the best that they can.
Absolutely. And beyond their diagnosis, which obviously sounds like it's very specific to someone, their treatment plan has to also, I'm sure, be very specific, like you said, to them as well. And beyond medications and treatments, what about lifestyle? So, what lifestyle strategies can really help someone with narcolepsy manage their symptoms, but also really improve their daily life or their quality of life?
So unfortunately, the lifestyle strategies could only go so far. And just because, hey, my brain is just dealing with lack of orexin so much that lifestyle strategies only are not gonna really be the fix all for these folks. But it can definitely make matters worse if your sleep schedule is very irregular or you're not prioritizing sleep. A lot of our narcolepsy patients already know that, hey, I need at least 8 hours of sleep or 9 hours of sleep. But if I'm not even giving myself opportunity to be in bed for 9 hours and I'm signing up for multiple projects or signing up for two, three jobs, then there is no way you're getting 9 hours of sleep. Then you're always dealing with insufficient sleep on top of narcolepsy. And that's a double whammy. And that's extremely hard to just neutralize with the medications. So even after medications, that's one advice that we give our patients that, hey, use the strategic naps. And that's another strategy, right? If I'm falling or feeling sleepy or feel like my medications effect has run out, somehow try to get accommodations at the job or at college or wherever you're working is to be able to take a strategic nap. And there is actually pretty cool website. It's called narcolepsynetwork.org. And that's a very good resource for our narcolepsy patients because it helps you learn more about your condition. It helps you look at all the resources that you can present to your employer, for the school, for college, and how to talk about this condition with your family. So those are some of the strategies we employ in helping navigating our patients with their day-to-day life.
That's so interesting that I never would have thought about this being a condition that you can potentially share, for example, with employers and things of that nature, school, for example, so that they're more understanding about the condition. That's really interesting, actually.
That's right. And typically they'll say, for example, for schools, they might give your child more time to finish testing. They might allow them to pick classes later in the day, knowing they'll have hard time waking up in the morning. So there are all kinds of accommodations, and a lot of teachers know because a lot of narcolepsy students have gone through those hallways. So it's a good resource to present to your school teacher or college professor, whoever is helping you with navigate that.
And yeah, that's also so interesting and difficult. For example, college, you can pick your classes, but for traditional high school students, that's really hard because you have that standard 7 or 8 a.m. first period class. So it's a struggle, especially when you're a teenager and you're getting used to your sleep cycles probably all over the place. So it's just interesting to think about how in college, for example, or certain times in life, there are ways to help navigate it versus sometimes there's not. But it's an interesting thought to have. I'm thinking back now, like, I think I might have a form of narcolepsy for sure. I've always had a lot of the issues you're describing, so my mind is just
And
spinning right now.
it's much easier with experts on your side to
Mm,
navigate it
that
because
quote.
otherwise you're just struggling all by yourself.
Yeah, and that's why the show is great because they're hidden. I took courses in sleep for psychology in college, and I love learning about these things. And these are things I have never heard. So this is it's such a good informative show. I really love this conversation. And beyond that, another thing that we speak about is how medicine overall is evolving, but sleep medicine is obviously constantly evolving. So what's some new research or maybe even emerging treatments for narcolepsy that give you hope for the future of patient care? Is there anything that comes to mind?
This is a thrilling time to be in this field. Like I mentioned earlier, once we realized what was the nature of the disease, what was the mechanism behind it, then all the pharmaceutical companies got to work, researchers got to work to find something that would replace that orexin. So think of just like thyroid. Hey, my thyroid gland stops making thyroid hormone. Guess what? We're going to replace that with thyroid hormone pills, right? So we're actually very close to be able to do that. And that's super, super exciting because we're seeing early clinical data from the research is very promising and exciting. So that's what I'm looking forward to actually be able to offer to my patients in real life. But even now, my sleep lab is one of the clinical research sites for these trials. So if you are, it's like, hey, I don't want to wait another 12 months because generally the medications are super, super expensive even to get, especially when they're brand new when they come out. So then research trials are a no-brainer to think or consider enrolling in those and have access to these cutting-edge medications and help move sleep science and sleep research forward.
Absolutely. No, it sounds like it's definitely an exciting time, and I think perfect time to share this and have this podcast, especially with that aligned timing. I think that this was such a great episode and informative as always. And today we really explored narcolepsy and one of the most misunderstood sleep disorders, and why so many patients live with symptoms for years before receiving the right diagnosis and the right care. And understanding these conditions is really just the first step towards better treatment and better quality of life overall for so many people who really struggle with this unexplained sleepiness. So, this was such a good conversation. And if you found this conversation helpful, make sure to follow the show so you won't miss future episodes. If it resonated with you or anyone that you think can benefit from hearing this show, which I think is probably everyone, make sure that you share it, send it. And it was a pleasure talking to you as always. I can't wait for our next episode and our next conversation. I know we have a lot of good topics on the way. So it was a pleasure speaking with you. And thank you everyone for listening to the Hidden Sleep Disorder Show. I cannot wait to speak with you soon.
Thank you, Lily.